Is there anybody who'd like to start us off?
I've got a question which is probably, to the panel really, but to Barbara, perhaps particularly. Well, there she is on the end there. Sorry to start off with you, Barbara. If I'm understanding things correctly, is John still here? John's still here. There's talk of what was called a relevant period. Was it for referral back into secondary care? Relevant discharge period. If I'm understanding that properly, does that mean that following discharge, there's a period of time when people can re-access secondary care, but it is a distinct period of time?
Yes, as currently drafted, the regulations which underpin that part of the measure, Part 3, propose that there be a time limit within which that entitlement exists. After that time, that entitlement falls away. Now, when we consulted on that and we included a proposed time limit, the majority of responses we got were quite negative. A lot of our respondents thought the whole concept of a time limit itself was wrong. And if we were going to impose a time limit, it should be much more generous than what we were proposing.
I suppose what I was going to suggest is that the relevant period as a patient is the lifespan, really. So I'm wondering what the rationale for that was, for that sort of finite period, really.
Well, that was based on when we were developing the measure policies. We spoke to a lot of service user groups, a lot of mental health practitioners, clinicians from all sorts of different disciplines, and we came to a view around the table that because the majority of mental health conditions do tend to not all, but the majority will have a tendency to remanifest themselves within a certain length of time. Perhaps the most sensible way to ensure that this entitlement didn't become too onerous on service providers, that there should be some cut-off point beyond which the service user would become, the individual rather, the former service user would no longer need that comfort blanket, that security. Phil may be able to elaborate on that. Phil was involved in some of those early discussions that we have. I'm not sure, Phil, whether you want to add anything to that.
No, I think the intent was that this was introducing something which was relatively new, not exclusively new, because some places had a self-referral back to secondary care for assessment, not an automatic right to have access to service, but certainly for assessment with a view that service would be provided. And I think that did raise some issues, because on the one hand people were saying this is something that we absolutely should be able to expect and not have obstacles to getting back into service. But on the other hand, some of the services were saying this might mean that we become very overburdened in undertaking assessments. I think that is a fair summary of the view that was expressed, and therefore there was a sense that there may need to be a balance, which was that in its introduction, that in the first instance there would be a time limit, so that you didn't have this kind of expanding group who might have an automatic right of assessment. Because if you remember, and if you've been in service long enough to cast your mind back to finding a place by the Wales Audit, the Audit Commission, who did their work, they were showing that there was 75% of CMHT time was going on assessment, with 25% going on interventions. I think that was the spirit of what was said. And what we don't want is to see the CMHTs and the secondary care service become an assessment-only service. We want to see them being much more therapeutic in delivering care, and there was a sense, therefore, that there may need to be a balance.
Thank you. Just on that, John, I don't know if you're able to clarify within that. You talked earlier on about within the 4 years there would then have to be a review. Clearly such timescales could be looked at again at that review of the measure itself.
That's a good point, Alan. I mentioned during my presentation this morning that the whole measure, every provision that will be introduced by the measure, will be subject to a full review and report process within 4 years of all parts of the measure coming into force. There are a number of things that may come to light in that review process that we haven't got absolutely spot on in the legislation as introduced. That will give us an opportunity to identify those areas and perhaps to, in a lot of cases, we can tweak regulations that we've introduced.
With regard to part one of the measure, what is it envisaged that the GP role might be? And how then, if there is a role envisaged, how would you iron out the inequalities from different levels of GP interest, different levels of GP knowledge?
Barbara, would you like to take the first
Thank
bite of that?
Well, my perspective on this, because a lot of this is about interpretation, if we go back to the original focus of the measure, the introduction of the local primary mental health support services, as well as being there to provide additional and improved services to individuals, is there to provide support and advice to GPs with a view to supporting them in their dealings with people with mental health problems. So my view would be that this new service doesn't take anything away from GPs, and we've just had this discussion to some extent in the workshop, but is there to support them and potentially increase their role. Now, that's without getting into any debates about capacity, which I know there are concerns about it. But overall, one of the prime objectives is to support GPs in their dealings with people with mental health problems in primary care. I think in terms of different levels of engagement, there are just no easy answers for that, unless some of my colleagues on the panel have got some insights into that. I think that, you know, as much of the implementation of the measure is down to local determination, and it's really how far the GPs wish to go and how effective the service can be in working alongside them and potentially increasing their wish to be involved.
I think, with a marker who perhaps would like to comment, obviously having a significant interest in mental health already. Have you any thoughts on that?
Well, the discussion we had in the meeting, in the workshop, I expressed some concern that GPs might see this as, oh, thank goodness for that, I don't have to do mental health anymore because there's somebody who's going to do it for me. And I think there's a real danger that needs to be made perfectly clear to our primary care colleagues that this is a support to enable them to do their work more effectively. It's not a substitute, because, I mean, we must avoid at all costs GPs becoming de-skilled in this area. We actually need to be upskilled in this area. So, and that's partly, I think, a communication issue about how it's communicated to GPs, practice managers and practice nurses, what the role of the mental health measure is. And it's made perfectly clear this is not a substitute for what we're actually doing, it's a support to what we're already doing.
Yeah. Okay. Sorry.
I was just going to say that for a long time now, the practice I was in has had a primary care mental health worker working in our practice, and this has been hugely good in terms of education for us and making GPs in my practice realise that there is a need to have an interest. And I think there's a possibility that people, through learning what can be done, will actually begin to see this is a help. So I need to take an interest, because it not only it makes the patient better, which one would hope would be their main aim, but it makes life easier for them. So being self-interested, they might just say, I'll go for it.
Okay. Next question.
Thank you. This is a question from the group, our workshop, where we were looking at the impact of mental health problems on children in that family. And the handouts we forgot to give are with Leslie, if anyone wants them on the way out. This question is from a very experienced general practitioner in our group. And he says, in view of all the measures, how will integration of these measures occur across the public sector and the third sector to ensure implementation takes place?
The offer.
Yeah, I mean, I think this was partly fueled by a discussion that we had within the workshop that we ran, which was looking at the interface between the Children and Families Wales measure and the Mental Health Wales measure. And there was a recognition that in the participants, some were more au fait with elements of the different measures that were coming through, and it was clear, I think the question that was asked raised the point, how do we make sure that one of the elements, certainly within the Children and Families Wales measure, is about moving away from siloed approaches to working with families towards a much more family-focused approach and a family intervention approach. But we'll only realise that if the people working in different elements of the service, so people in children and family services and people working in mental health services and people working in substance misuse services and people working in domestic violence services, know, A, that the measures exist, B, what the measures require, and C, change their behaviour accordingly so that we actually get the response that we need. So I think there are a number of issues for me. One, when we go to the point of implementation of the various measures, we don't just go to the usual suspects. We make sure through our engagement of chief executives of local authorities, chief executives of local health boards, chief officers in the police service, that we are getting wide buy-in to the variety of measures that are taking place. There are a significant number. There's the carers measure, there's the two that I've mentioned in detail there. There are others that are coming along, and we need to make sure that we understand the roles of the various agencies in fulfilling the statutory duties in the various measures, that we are cascading that information appropriately to the wide network of people that we need to, and hopefully we're also, through the training to support those, engendering the culture change and the behaviour change that's required to make those measures a success. And I think without all of those steps, there's a real risk that we will carry on working in very siloed ways, responding to what we see as being our business in terms of the measure that we think refers to our service, where actually, when you look at the intent of the measures, Welsh ministers are looking for a much broader approach to these things and asking people, you know, we use the phrase and it's overused, it's everybody's business. We do need to make sure that everybody is aware of what their business is in realising the intent and spirit of the measures.
I wanted to ask Dr. Crossley a question after the IAPT workshop, and you mentioned something about 5 areas for gatekeepers. And I'm just wondering about gatekeepers and which kind of gateway you were referring to, whether it's kind of in reference to the gateway into primary care or whether it's between primary care and secondary care. I'm asking that from a kind of a counselling perspective, so counsellors currently in primary care, what the impact that would have on kind of counselling currently.
Yeah. Actually, Barbara might be able to help me out on this too. It's as I understand it, the gatekeeping role is not really been determined with the primary mental health support worker role yet. As sort of that's what will happen. Is that right, Barbara? But they will have a function in terms of the wider system of referring into secondary care. But that's not to say that they will be the only way in which secondary care is accessed by any means. The other thing, I guess, about the way in which it's been thought of hitherto is that the work that the primary mental health support worker gets will be via the GP. All right?
Yeah, I think that we haven't really used the term gatekeeper in relation to the primary mental health services under the measure. And I think it's important to appreciate that people will come into these services either via the GP or via secondary care if local schemes allow for that. So it's not an open access service. So they will already need to have contacted another service before they come into the local primary mental health support service. Once they're in, that service has a function of assessment, which would then indicate whether they could have their needs met within that service or whether they needed to be referred elsewhere or back to the GP. But I'm just a little bit nervous about that being badged as gatekeeping because I hadn't sort of used that description around it. I don't know if that helps.
Yeah, it does help.
Okay. Do you have any more questions? Not a problem if people don't. Okay, we'll draw a line there.